Please start the summary. Got it. No. Yes, ready. Yeah. So, my warm welcome to all of you. 189th edition of Thursday Musings we are having today. A very practical, important topic on from a very learned speaker who has experience in this field, evidence-based management of autism spectrum disorders. So everyone is on the mute mode. The panelists will be able to unmute themselves. Questions are invited in the chat box. These will be taken up by the moderators to the presenter. So next slide, please. I'm handing over the session to Professor Dr. Tufanpati sir, who is the chairman of this program. Sir, over to you.
Thank you, Dr. Ali. I welcome everyone to this 189th edition on this nice topic of evidence-based management of ASD. And formally, I welcome and introduce Dr. Alim Siddiqui and Dr. Amrit Patajoshi, respectively the office bearers, treasurer and secretary of IPS, here in the teams from the very outset, as well as Dr. Vishal Chabra, who is vibrant and joined over last few months as a very active moderator. He is currently HOD and senior consultant Fortis Hospital, Shalimar Park. And he has got 15 published articles, currently immediate past president of DPS, and was president, vice president, and general secretary of the society. He is also currently co-chairman of IPS membership subcommittee. His areas of interest: phenomenology, mood disorders, anxiety disorders, addiction disorders, psychopharmacology, and neurology. Welcome all the chairpersons, all the moderators. Next slide, please. Next slide, Shreya. Chairpersons, we have got a senior psychiatrist, Dr. Mamta Sood. She is professor and ex-major of Army Medical Corps. Current affiliation is AIIMS, New Delhi. Achievements, publications 155. Books edited 4. Awards 9. Currently President IPS North Zone. Vice President Indian Association of Social Psychiatry. Areas of expertise and interest: severe mental illness, mobile technologies and mental health, have designed mobile apps for chronic and fast episode psychosis. Welcome, Dr. Sood. Next slide, please. Dr. Manjari Deshpande, consultant psychiatrist from Mumbai. She got DNB in psychiatry and philosophy of old and adolescent psychiatry, child and adolescent psychiatry. India's Child Guidance Clinic, ICGSC. 5 centers in ICGSC in India. Multidisciplinary center consisting of all therapies under one roof, practicing exclusive child and adolescent psychiatry for the last 10 years. Welcome, Dr. Deshpande.
Thank you, sir.
Now I hand over this session to the chairpersons, and I will request Dr. Cho to introduce our speaker, Dr. Satyaraj, and Dr. Anjay to introduce the topic. Over to the chairpersons. Mamta Madam to introduce the speaker.
Thank you, Dr. Pati, Dr. Vishal, Dr. Alim, and Dr. Amrit for a lovely introduction. It's my proud privilege to start this 189th edition of the Thursday Musings. And we have a very illustrious speaker with us today to talk about management of autism spectrum disorder, Dr. Satyaraj. She has done DPM, MD, and DNB in psychiatry. And she's also fellow of Royal Australian and New Zealand College of Psychiatrists. She has worked in Australia for long periods, and she has worked in the child and youth mental health services. She has been consultant in infant mental health, and she has been trained in Circle of Security. She has got many academic awards, including she was awarded gold medal for securing highest marks in MBBS in 2001. And she was awarded Dr. Rose Checo Medal for even best outgoing student in MD. Then Sharda Menon Gold Medal for securing highest marks in DNB exams. Then Michael Hong Travel Fellowship. And she has got many travel fellowships. She's member of Royal Australian New Zealand College of Psychiatrists, Life Fellow of Indian Psychiatrists, Life Fellow of Indian Association of Child and Adolescent Psychiatry. She has been on executive council member of many associations. So Dr. Satyaraj, welcome for this session. I will hand over to Dr. Manjari Deshpande to introduce the topic. Thank you.
Thank you, ma'am. And thank you to the organizers for having me here as a chairperson. And it's a pleasure to hear Dr. Satya, and understanding how much work she has done and the kind of accolades that she has won. So today's topic, yes, being a very important topic. I practice exclusive child psychiatry, and I think even as an adult psychiatrist, one cannot deny that invariably every day, I think some of us must be encountering a neurodevelopmental condition. And the statistics are only increasing. Now, the latest statistics being 1 in 23 children almost diagnosed with autism spectrum disorder. It is increasing very, very rapidly. And yeah, unlike other conditions where we have an armamentarium of medication to be used, that's something that is lacking in autism spectrum disorder. The evidence for medication use is definitely limited. In cities like Mumbai, Delhi, I'm sure we have multidisciplinary teams and catering to occupational therapy, speech therapy, remedial, doing everything that is needed. But I think in 2-tier and 3-tier cities, of course, getting such experts is difficult. And of course, it's not that autism doesn't happen in other parts of the country. So I think as a standalone practitioner and what can we do as psychiatrists in autism is something that we would look forward to hearing from Dr. Satya. So please take us through the presentation of autism and enlighten us on the latest trends in this disorder. Thank
I'd
you.
like to thank the IPS Odisha branch for giving me the opportunity, and I thank the chairpersons, Dr. Mamta and Dr. Manjari, for the kind words of introduction. So without sort of going too much into the other things, I'll share my screen. Hopefully, give me a second. Is that visible, sir? Is it visible to all? Yep.
Yeah.
And I'll try to make it in the slideshow.
Yes,
as well.
going well.
Okay, so hopefully I've tried to give a balance of academic sort of data, and of course, definitely more on the clinical perspectives, as I know people from different backgrounds who have the ability to sort of have small setups, and also some people who have multidisciplinary teams. There are different types of sort of participants in this meeting, so I hope I would cater to most of them. And in case there are any questions at the end of the session, I'm more than happy to take them. So just to give you an introduction, I'm come from CMC, so I'm a professor in child and adolescent psychiatry, and bringing greetings from Christian Medical College, Vellore. We have completed more than 100 years of medical education. So I'd like to deal with the topic just to give you a broader outline about the definition, prevalence, and diagnostic criteria. That would be for a very few slides, and then moving on into identification and evidence-based management. I think most of my emphasis of my presentation would be in this area. So what is autism spectrum disorder? As all of us know, it's a neurodevelopmental disorder characterized by significant impairment in two areas like communication and social interactions, with a lot of repetitive behaviors and restricted stereotype interests. So what is the difficulty with autism? There is a wide clinical heterogeneity. So what do I mean by that? Every child or every case you see is very different from what the textbook can describe as well. So having to know about these children and then tailor our management to their needs is the success of the treatment. So quoting Miles et al. From 2005, he gave a description of what is the difference between the essential autism versus a complex autism. Just to give a touch on what complex autism is, it usually starts off with early disruption in the morphogenesis, causing a lot of dysmorphic features, maybe microcephaly and early onset changes, EEG abnormalities. And this is the difficulty when we see with complex autism. Essential autism is usually the other types of autism, where there is a typical speech and language delay, a regression, and the heritability in such cases have also been proved. Most of my slides have my references at the end of the slide, and I've given a list of references at the end of my presentation as well. I'm more than happy to take questions at the end. So autism, as we say, initially our understanding and now moving on into a spectrum disorder concept. What does spectrum mean? As you can say, it's a range of abilities and a range of impairments as well, which occur with people in autism. So earlier, if you remember, when we had sort of possibly when I was training, I would say we spoke about autism, atypical autism, Rett's, and then about Asperger's, childhood disintegrative disorder, and a PDD NOS category. From there, now we've moved on into a spectrum concept, and our changing is slightly different from how we look at autism now. So diagnostic characteristics, as I mentioned earlier in my first slide, impairments in social communication and presence of restricted and repetitive behavior. So what is like this communication deficit? What are we talking about? So they have problems in reciprocating normal social interactions, understanding what people mean. So they misinterpret social cues, and that relates to a lot of problems as well. Severe problem in maintaining relationships, in initiating conversations, in maintaining conversations, and even non-verbal communication. For example, like eye contact, waiting for their turn, prosody of speech. Many of these things are affected as far as autism spectrum disorders go. And definitely 2 of the 4 symptoms of the restricted and repetitive behaviors. So stereotype behavior, stereotype speech, motor movements, excessive adherence to routines, or a rigid pattern, as we say, ritualized behaviors. All these are very clearly seen in ASD. And of course, sensory issues. So it can be either a hypo or a hyper reactivity to the sensory input from the environment. So what are the prevalence? So the latest, as I said, the prevalence depends upon multiple things, depending upon where you're studying it, in a community, in a clinic setup. What is the age group we are targeting? What is the criteria we're using for diagnosis? All this would depend on the prevalence rate. So there's a wide range of prevalence. I'd like to quote for Indian from Aurora et al. That was in 2018, where the global prevalence was roughly about 1%. In India, it's about 1.5%, and in the US, about 1.7%. And also, as all of us know, there is a male preponderance, and most of the children, we say about 1/3 of them, do have associated intellectual disability. So when we're looking into the multi-axial diagnostic perspective and management, this would show why is it more relevant in our case. So I'm sure that there are multiple psychiatrists who have joined the meeting and pediatricians as well. Why is it important for pediatricians? As you can see, like there's a very nice article in 2022 by Singhi et al., where they had said that usually the first port of call is always a pediatrician. They're being followed up for vaccination, for common cold, cough, and therefore the pediatrician has the multiple opportunities to actually keep an eye on the developmental progress of the child. And now, as you can see, there's significant increasing awareness among pediatricians about childhood autism. And you can see that the trend where the ASD diagnosis has been made much earlier compared to the previous decade. So I'm not sure how clear is this. Basically, it's a pathway of diagnosis. So once you identify a child with risk of ASD, so when there are red flag signs, what are the initial developmental assessments you do? In case it is consistent with ASD, then move on into the diagnostic assessments and then definitely give them into a treatment pathway, you move them. If it is not consistent with ASD, then definitely keep them on surveillance and monitor to see for the developmental progress, especially in the social communication and language domains. This was given by Levy and colleagues. So what do we look for in a child? So what are the red flag signs in case the child does not show this in, let's say, 12 months of age or 14 months of age? That shows us a red flag that there is some deviation in the trajectory of social or language development, and maybe need to sort of intervene and look at it earlier. So does not respond to their name call by 12 months of age, does not point to objects to show interest by about 14 months, no pretend play by 18 months, avoiding eye contact, wanting to be alone, has a difficulty in basically understanding. So possibly mama is shouting, but this child is giggling and does not understand or interact, the social cues are not picked up, then that is a red flag sign. Has delayed speech and language skills, and usually is upset with very small changes in the routine. So this is the rigidity I was talking to you about. Has certain obsessive interests, and of course, definitely a lot of repetitive behaviors and sensory issues. When a child is said to have these features, then definitely we must be thinking of a ASD spectrum and do the necessary investigations. So screening tools, there are multiple screening tools available now. The most commonly used is the MCHAT, which is freely available. You have the infant and toddler checklist, you have the SCQ or the social communication questionnaire as well. So these are screening instruments for diagnosis. Definitely you have a gold standard, that is the ADOS or the Autism Diagnostic Interview, Autism Diagnostic Observation Schedule, and the Autism Diagnostic Interview or the ADI. So all this can be commonly used for early identification. So we are going to talk today about what is evidence-based medicine. So it's just not like putting a few things together and saying that this is evidence-based. It's about integrating the individual's clinical expertise with what is the best evidence available. As you can see, the levels of evidence, the maximum evidence base goes to meta-analysis and systematic reviews, which are at the top of the pyramid. And we'll try to see what are the types of interventions which have good evidence base for autism spectrum disorders. So focusing on two types of interventions, one is the comprehensive treatment models and the other is the focused intervention practice. So what are the comprehensive treatment models? Most of us know about it. So it is either the LOVAS, the ABA, the TEACH program, or the LEAP, learning experience by alternate pathways, or the Denver model, early start Denver model. All these are very well established comprehensive treatment models which have a significant evidence base available for ASD. So what do I mean by a comprehensive treatment model? So they have a conceptual framework. It is usually having a manualized procedure, and the intensity or the number of sessions is multiple hours per week. Most of them are 5 to 6 hours per week involved in the comprehensive treatment models. And of course, it is across a time period of a year or more in most of them. And the outcome is on multiple domains. So it's not just, say, socialization. It's not just language and communication, behavior, social competence. So multiple targets are there, and that is why you call it as a comprehensive treatment model. How does it differ from the focused intervention? Focused, as the very name says, you're sort of designing your intervention for one particular skill or one particular goal to be achieved with for autism. For example, let me give you a very practical example of discrete trial teaching. As I'm going on into my multi-axial presentation, I will lead a little more into that topic. So a focused intervention is taking one particular area of the ASD and trying to work on that and have that as an outcome. So as I understand, as there are multiple clinicians as well joining us, so I thought it would be interesting to give a case scenario and then work on it from a multi-axial perspective so that we'd be able to sort of relate to it more easier. So it's a 3-year, 9-month-old male child coming from a middle socioeconomic status background. He was a second child born to consanguineously married parents. Elder sibling was a girl child who's 6 years old, who's perfectly fine. Right. So what are the complaints with which the child presents? A speech delay, no meaningful words at 3 years, 9 months of age. So definitely there is an issue there. Inconsistent response to name call, preoccupation, fleeting eye contact, unable to indicate toilet needs, decreased socialization with peers, solitary play, enjoying shadow play as well. Repetitive behaviors, a cluster of behaviors I've described, hand flapping, finger gazing, jumping, lateral gaze, multiple repetitive behaviors are seen. And of course, behavioral problems. In the behavioral problems, there is adamancy, temper tantrums, hitting self and other things and hitting others. Of course, self-injurious behavior is something very important in children with neurodevelopmental disorders, specifically in children with autism spectrum disorder as well. I'll try to highlight it a little more as I'm going into my multi-axial presentation. Sensory issues like aversion to sticky substances and ear plugging is also reported. Sleep disturbance and a very fussy eater. That's how the mother describes the child. Right. So birth and development, antenatal period was supervised, nil problems, full-term normal delivery, normal birth cry. So not a lot to suggest a very difficult perinatal or antenatal period. It was a fairly smooth sailing one. Medical history, the vision and the hearing were tested and it was normal, nil medical comorbidities as well. And past history has been seen by a pediatrician actually during a regular vaccination visit and was advised follow up with a child psychiatrist. So this is the case. I'd sort of like you to have this in your mind. And then with that, let's try to sort of have a look into the multi-axial diagnostic presentation. So this is given by Rutter. This was a multi-axial diagnosis for neurodevelopmental disorders. So axis 1 is your level of intellectual disability or your developmental delay with or without behavioral problems. Axis 2 is your etiology. Axis 3, your medical comorbidity. Axis 4 is your psychiatric comorbidity, and axis 5 is the psychosocial situation. So why do we need a multi-axial diagnosis, right? 2-3 main reasons is once you're giving a multi-axial diagnosis, you're looking into a broader biopsychosocial approach for looking into a child. It's not just a diagnosis given. You're looking into a child more holistically. Therefore, the plan you form for a multidisciplinary treatment approach is going to be very effective as well. It easily helps us to communicate. For example, if I say a multi-axial diagnosis, I'm sure that's the same Dr. Manjari or Dr. Mamta will also feel, or any of us who are seeing a child of that age. So it's easier for communicating a treatment across clinicians, right? It helps in formulation, it helps in a holistic treatment plan, and definitely getting all the complex data together and giving a concise sort of way of formulating a multi-axial diagnosis is able to do. So moving on to this case, and now I'd be talking about the multiple axis, and each axis, what is the evidence-based treatment we are having at the moment. So axis 1, if you take, is the level of intellectual disability or the developmental delay, as I said, with or without behavioral problems. So in the axis 1, so how do you measure the developmental delay? So 1 is a social maturity assessment. You usually use the Vineland Social Maturity Scale. This is what we commonly use in our center, or the VABS, Vineland's Adaptive Behavior Assessment Scale can be used as well. For developmental quotient assessment, Gessel's can be used, Bailey's, Mallin's, Ages and Stages questionnaire, multiple other assessments are available for assessing the developmental age of the child. And of course, for the intelligence assessment or for IQ quantification, Binet Kamath and Wechsler's are the most commonly used. And of course, Binet Kamath, as all of you know, is a version of Stanford Binet, which has been validated for the Indian population. So this is my diagnostic measures I would use for my axis 1. Moving on to a little more. So I said this has 2 parts. The first part was a adaptive skill. So I'm looking into a developmental quotient. My other second part of it is with or without behavioral problems. And a very important tool we can use for this is known as the basic MR, which has basically 2 parts, one dealing with the skill behaviors and the other dealing with the problem behaviors. It gives you a very neat score for each of the domains. In an undesirable behavior, you have 10 behaviors described, say like temper tantrums, misbehavior with others, self-injurious behavior, odd behaviors, hyperactivity, and each of these are rated on a Likert of 0, 1, and 2. So you're able to get a severity of the behavioral problems as well. So now that you have an axis diagnosis, right, we can move on into management of this axis diagnosis. 2 other modules which we use in our center, which is very useful, is the Carolina curriculum. So this is the North Carolina curriculum for infants and toddlers and the Carolina curriculum for preschoolers. What do I mean by this? I'll just give you a snapshot. Hopefully it's visible. So this is an assessment. It's a module-based assessment. Usually our therapy is a parent-mediated therapy. So with the help of the therapist, across the domains of, say, cognition, communication, fine motor, gross motor, and social adaptation, the parent sits down with the therapist, looks into the module, and rates the child. So for example, you see the red color for the 0 to 3 months on top has an A, B, C, D, E, and that is colored red. So what does it mean is these are skills described in the module. And if the child has or possesses these skills, they get a shade for that. Let me go on to say possibly the 9 to 12 month or 12 to 15 month. So you see another shade, you see a green color. So actually what we do is a pre and a post assessment. So the red one is the skill the child had pre-intervention. So before intervention, we have a baseline assessment being done, and post-assessment, the gains the child has made. So obviously the skill in the 12 to 15 month level in the cognition, as you see H and an L, was not present in that child in the pre-intervention period. Post-intervention, these are the skills the child has got. So as you see, it's done across the 5 major domains, similar to our Gessel's developmental schedule as well. And this is called as the Carolina curriculum for preschoolers, where it moves on into, if you see, 2 to 5 years of age. So this child, who was roughly functioning at somewhere near 18 to 21 months, has made gains and moved on to somewhere near 2.5 to 3.5 years of age, with a varied presentation across the domains. The communication, as you can see, still has not picked up that much, as the child has severe autism as well. So what are the interventions? So before moving on into interventions, as I said, one more assessment. Usually when there is a child with developmental delay alone, they are cooperative sometimes for an assessment of a developmental quotient. But the challenge is sometimes when the child is not very cooperative, you do not get a formal assessment of the DQ level through a Gessel's or a Bailey's, etc. So PEPAR is more of a psychoeducational profile revised. As I said, it clearly gives you the domains of imitation, perception, fine and gross motor, and cognitive, verbal and cognitive performance. So across these domains, if you see, again, as all of you can see, there are 2 sort of sketches seen. So the one in the bottom, you see that the assessment is being done pre-intervention as a baseline. And once following the 3-month intervention, the post-assessment is again done. And that you can see the child has made gains in areas like cognitive, verbal, cognitive performance, imitation, and multiple of these areas. So what is the treatment modality? So axis 1, I'm focusing on 2 things. One is building the adaptive skills and decreasing the problem behaviors. So we've done the assessments, we've got a DQ, we've got a basic MR score. So now I have to move on to intervention. What are the common interventions which have maximum evidence base? Applied behavioral analysis. So as all of us know, this is one of the evidence-based management practices. It's application of a learning principle to produce a meaningful change in behavior. You use a contingency model. So how you basically do it, I make a list of the antecedents, the behaviors, and skill acquisition would be the primary goals for a child we are working with in this area. So ABA, there are multiple studies which have been done. A meta-analysis showed as well that there is significant medium to large effects in functioning, basically language development, adaptive behavior, and other such areas. So practically, let's see. So all of us talk about ABA. So what we do there are 3 major things I would sort of want all of us to know about. One is a task analysis. So for example, I'm teaching a child the skill of brushing, right? I don't say take the brush, put the paste on it, brush, and then spit. So there are multiple skills involved in this, right? Making front strokes, side strokes, learning to spit it out, then learning to gargle. So breaking the skill into smaller parts and teaching them in a structured manner, one goal at a time, and providing the prompting. What do I mean by prompting? So first time when I'm teaching the child, I will be giving maximal visible physical prompts. So what do? I would actually hold the child's hand with the brush and show the child how to do the front strokes. Then I move on to decreasing my physical prompt to moving on to a verbal prompt and then fading that away as well. So when this is done in a very graded way, the task is learned. Once small bits of all the task is learned, then I chain it and put together. So I know how to now brush my front strokes. I know the side strokes. I know to spit. Now I put it all together for the child, and the child does the task as a chain or as a series of activities. So this is the task analysis, and teaching the child is one of the basic principles we use. And how do you make a child learn? As all of us would know, it's the behavior therapy principle of rewarding and reinforcement. So when the child has a particular sort of learned a thing, you're going to positively reward the child with a reward. Is anything with the child will work for, anything the child desires a lot to have, that is going to be your reward. So it can be a tangible reward, it can be something like an edible reward, it can be a social reward, it can be multiple things. So you try to change the reward so that a satiety doesn't happen when you're teaching the child. So I did mention that this is one of the ABA has multiple sort of evidence-based articles published. Right. I was talking to you about a focused intervention, if you remember earlier, about the discrete trial teaching. This is exactly what I had explained in the task just now. Breaking a task into smaller parts, teaching one sub-skill at a time, repeatedly practicing that skill so that there is a mastery of that skill. There must be consistency in teaching as well. It's not that I teach that skill today, leave it for 4 days, and then go on the 5th day or the next Monday and start again. That doesn't work. So a consistency in teaching the child must be maintained so that the child is able to gain that skill adequately well enough. Once that skill is gained and mastered, then I move on to the next skill. And then I do a chaining, as I had mentioned earlier. So this is how you usually go back about discrete trial teaching. You have an instruction, there is a prompt. So the prompt, as I said, can be a maximum physical prompt, moving on to a minimal physical prompt, a verbal prompt, and then moving on to the child being able to do it by themselves. And how you get to do them? By giving them a feedback of their behaviors and positively reinforcing their learned skill behaviors. So early start Denver model, again, is one of the evidence-based sort of thing. Here, it's usually, as the word mentions, it's early start. So it's used from 12 to 48 months. So less than 4 years. It's again based on the ABA principles. Here, play is used as a medium to teach the child both the language, social, and the cognitive skills. The flexibility of this sort of model is that it can be used at home, it can be used at a school setting, it can be used at a clinic setting. You can do it one-on-one, or you can do it as a group therapy as well. Moving on into my axis 2. So all we have dealt till now is the level of developmental delay and the behavioral problems. That is your axis 1. We learned about the assessments and the management. Now moving on into etiology, right? When talking about neurodevelopmental disorders, and in specific here about autism spectrum disorder, there are multiple etiologies. So you can talk about for the next 2 hours about etiology of autism as well. So the most commonly accepted model is the GE model, or the gene environment interaction model. And of course, as all of us know, there is an epigenetic load and a genetic load. Where does the genetic load come from? It can be either de novo mutations or a familial genetic variant being carried on. So when the GE, so the genetic and the environmental influences, when they come together, so both nature and nurture, when there is sort of loading, that is when the expression of the autism spectrum disorder happens. How does it come? So there are compromised neurodevelopmental pathways resulting in decanalization process being affected. Abnormal postnatal brain maturation happens, and therefore there is a dysfunction in the specific neural circuitries involved in autism spectrum disorder. So when do you do an etiological workup? So I want to emphasize this because usually the etiology we work up depending on the place we are, right? Suppose I'm a primary care physician practicing in a rural area. I'm not going to be able to do most of the etiological assessments, and there is no need as well. So if I'm in a tertiary care center, I have the luxury of being able to do an extensive etiological workup with all my colleagues in, say, developmental pediatrics, pediatric neurologists, you name the department, and I can sort of get the referral and the etiological workup done. But that might not be needed for a majority of children with ASD. So the clear guidelines, when do I do an etiological workup, is when the family is not complete. For example, the family is planning to have another child. This child has a lot of clear dysmorphic features. You're worried about the next child also having, because you're worried about a major genetic component. Definitely, yes, then send the child for medical genetics workup and a counseling as well. Blindly never chase the diagnosis just because we want to get a diagnosis and etiology of why autism for my child, because we usually do not end up finding any answers for our questions. And as you know, all these etiological workup are very, very expensive as well. And the intervention you're going to do at the end of the day is not etiology based. So if it doesn't mean if I have, say, for example, Fragile X with ASD symptoms, my intervention is different from another child presenting with a typical developmental delay with ASD. So the interventions are not etiology based. So how much should we actually waste money on doing an etiological workup is something each individual clinician needs to identify and work with the family. Axis 3, again, it's very important for holistic therapy of the child. Axis 3, if you take seizure disorder, sensory impairments like hearing, vision, or cerebral palsy are the common medical comorbidity. As I said, if you're comfortable as a developmental pediatrician treating the seizure disorder or a child psychiatrist, you can go ahead and do it. Or we can always involve the referrals as needed, the pediatric neurology, developmental pediatricians, ENT, ophthalmology, and physical medicine and rehabilitation can be involved to get the multidisciplinary input as well. Axis 4. So Axis 4, what happens? Axis 4 is usually all your autism assessments. Your psychiatric, here we're looking at autism. So what are the assessments we do in our center? We do a childhood autism rating scale, or the CARS. It is a severity assessment of autism. So you have a mild and moderate cut, which is up to 36, and a 36.5 for severe autism. And this child, as you can see, has a severe autism score as well. The other autism assessments, as I said, a diagnostic assessment is a autism diagnostic observation schedule, or the ADOS. Definitely here the domains most of us know. The domains are communication, reciprocal social interaction, play, and stereotype behaviors. So you have a cutoff for diagnosing autism. So anything above 12 is diagnosed as autism, and children with a spectrum cutoff is usually 7. So these are a few studies which have been done in our center for diagnosis of autism, validating the CARS rating scale and the psychoeducational PEPAR, or the psychoeducational profile modified. What are the common assessments used in India as well? Definitely, we must know about the ISA, or the Indian scale for assessment of autism, the severity rating, and of course, for getting the benefits of disability, this is used as well very widely. So a little about ISA. What is it? It's a 40-item scale. There are 6 domains in which the different questions are given. That is the social relationship, reciprocity, emotional responsiveness, speech and language communication, behavior patterns, sensory aspects, and cognitive component. So each one of them, as you can see, as I've given in the side, have a different number of questions, and they are sort of rated again on a Likert from 1 to 5, and you get an ISA score. So the ISA score can range anywhere from 40 to 200, right? So a mild is somewhere from 70 to 107, and a severe autism spectrum disorder would get a score of 153. So this again is very widely used in India, and it's it's easy to sort of use and train as well. Looking into Axis 4. So Axis 4 was the psychiatric comorbidity we are looking at as well. So what are the comorbidity we are looking? So we dealt with developmental delay, which was because it's a neurodevelopment. We presented it in Axis 1, right? The other psychiatric comorbidity, again, you can have seizures, you can have sleep disturbance, you can have ADHD or attention deficit hyperactivity disorder symptoms. You can have feeding and eating issues. Feeding disorder because children less than say 0 to 3 years of age present with a lot of feeding difficulties when you're seeing them being on the spectrum. Of course, in older children and adolescents, mood disorders, anxiety, and OCD are very common as well. So what are the differential diagnoses you would look into when you're looking at autism spectrum disorder? You're looking into whether there is only a developmental delay, just a speech and language disorder, is it selective mutism? The most common thing which I'd like to mention is about attachment disorders. So there's been multiple research on, are these children having a delay in social and communication skills because of early onset trauma, because of early onset attachment disorder? So then you sort of have to differentiate it from autism. I'm sure we'd sort of be able to discuss a little more about it during our discussion. But one of the measures used to differentiate is known as the Coventry's grid, where you can clearly differentiate clinically between an autism spectrum disorder and an attachment disorder. Other genetic conditions giving a ASD-like behavioral phenotype can be present, and of course, hearing impairment and other anxiety and selective mutism-like conditions where you're going to try to differentiate from autism spectrum disorder. What are the interventions for ASD? I had mentioned earlier about the ABA, about the Early Start Denver, the discrete child teaching, and multiple modalities. So you're looking at structured educational and behavioral interventions. That is the first part. Developmental interventions and specifically interventions for communication. So here you can also use your developmental speech and language assessments. You can use something known as reels, and then you can also use sometimes as a treatment modality if the children are predominantly nonverbal, even the picture exchange communication system or the PECS can be used. Interventions for ASD, I've tried to look at it from non-pharmacological and pharmacological. Non-pharmacological, we had discussed about. Going on into a very brief description about the pharmacological interventions of ASD. So just to present a Cochrane review, more than 17 reviews were included in this study. They found a very weak evidence-based for all sort of modalities of treatment like acupuncture, gluten-free, casein-free diet, music therapy, social skills, theory of mind, cognitive model, multiple models. This is a meta-analysis done by Larissa Lera in 2017. It's a very nice read and I'd encourage the same. And there are no benefits found from other therapies like chelating agents, hyperbaric oxygen, omega-3, megavitamin diet. All this does not have an evidence base. What and when do we use medications in autism? So currently the pharmacological interventions, as Dr. Manjari had mentioned at the start of the session, are primarily only to ameliorate the challenging emotional and behavioral symptoms of ASD. So treating with medications is not a cure for ASD, and therapy is the only way out of the social, language, and communication deficits. So where do I use medicines and how do I use them judiciously? So when there is inattention, hyperactivity, compulsive behaviors, anxiety, sleep disturbance, then definitely medications can be used. These are the common indications. And as I had said, self-injurious behavior in children is another very important area where definitely medications are used. So a little more into the self-injurious behavior I'd try to explain. Depending on the type of self-injurious behavior or the topographical description of the self-injurious behavior, the medications or the pharmacological management can be more closely tailored. So if it is more of a repetitive sort of, say, repeatedly rubbing the mouth or repeatedly mouthing and having a callus formation, then most commonly we feel that the putative neurotransmitter here could be the dopamine, and therefore you treat it with a low dose of an atypical antipsychotic like risperidone, right? If it is going to be a very severe self-injurious behavior, I think most of you would have seen that as well in some cases where they actually chew off their fingers also, like say Cornelia-de-Lange syndrome. So in such, or the Leach-Nahan syndrome, where even the tips of fingers are chewed off by these children, it is more sort of considered as an opioid hypothesis, and therefore naltrexone can be given as a medication of choice for these children with this particular type of self-injurious behavior. You also have another self-injurious behavior where there is more of repetitively doing it and getting very, very agitated when you stop. So how does that sound like? It's more like an obsession, like obsessive need to do it. And when you stop, I get very upset. I get very angry. I get very irritable. That's like typically me preventing you from doing an obsession. So here the serotonin is the possible putative neurotransmitter, and SSRIs can be used for managing them as well. So common medications which have been approved by the FDA, risperidone and aripiprazole, can be used for children and adolescents with repetitive behaviors, with irritability and with aggression as well. SSRIs, SNRIs, they're said to have very minimal effect with the repetitive behaviors, but definitely they can be used if there is anxiety and depression comorbid present in the late childhood or early adolescence. It can be used very effectively. If there is a comorbid ADHD, which you see in more than 50 to 60% of children with ASD, definitely the first line of medication can be methylphenidate, a stimulant, can be used, or in case you can also try a tamoxifen or SNRIs. Clonidine can be tried in case there is multiple comorbidity, a severe sort of intellectual delay with self-injurious behavior, with hyperactivity and restlessness. So basically, depending on the type of presentation of the child, you can basically try to manage your pharmacological treatment as well. Definitely, as I said, clonidine and guanfacine. Guanfacine is not available here, but clonidine definitely can be used in the treatment of ADHD symptoms when there is a comorbid ASD presentation as well. Sleep disturbance, as I said, can be seen in children with autism spectrum disorder. Definitely, first line of management, sleep hygiene techniques. If it is not seen to be improving with that, then melatonin can be given. It is a time-limited trial you give to see how much of improvement is there, and it has to be used in addition to the sleep hygiene techniques. So what do I mean by sleep hygiene techniques? Going to putting the child to bed at the same time, avoiding daytime naps, trying to give the child, say, a routine for the bedtime so that the child is able to basically calm down and sleep into the typical cycle every night. So that has to be done in addition to the melatonin as well to see a significant clinical improvement. A lot of people ask us this question about complementary or alternative medicine. So definitely 50% of families who have children with neurodevelopmental disorders and ASD do go to complementary or alternative ways of therapy at some stage in their treatment plan. It is just a desperate call, would something help my child? I think, and that is why we need to explain to the parent even before starting a medication, what is the target symptom? Why are you planning to give this child this medication? How long are you planning to give this child? Psychoeducate them about the side effects. Psychoeducate them about the target symptoms. So for instance, I prescribe risperidone for a repetitive behavior for a child or an SIB, self-injurious behavior. And then 8 weeks down the line, a mother comes to me and says, Doctor, the child abhi bhi nahi bol raha hai, kya karu? Right. ये बोलने के लिए नहीं दिया गया था must be mentioned very early on. Right. I think Explaining that and psychoeducating the parent to a target symptom as to what you expect with the medication is very essential. So who move on to these alternative form of medicines? Usually children with a lot of GI symptoms, with uncontrolled seizures and excessive behavioral problems and sort of hyperactivity, they tend to sort of go into alternative medicine pathways to see if that would benefit the child. So psychoeducation of the parent is very, very, very essential. What are the therapies which we have? As you see, by the day, if I do this presentation now and possibly by in the next 3 months, I have to do a review of literature again to see, because by that time there are multiple more medications which sort of shown to show some effect in autism spectrum disorder. So oxytocin initially was like social impairment in ASD. It has a good sort of maybe in a particular subgroup of children, but has no evidence based for regular use in all children. Arbaclofen, memantine, N-acetylcysteine. So many of these medications have been sort of emerging therapies suggested for autism spectrum disorder, but no clear evidence base for any of these treatment modalities. And of course, stem cell therapy, hyperbaric oxygen therapy, specific diets, a casein-free, gluten-free diet definitely doesn't have an evidence base. Secretin, by actually not giving your child, so any child enjoys chocolates or ice creams. By not giving that to your child, actually, I think you're decreasing the quality of life of the child, but you're not going to help the child in any way. Is it helpful in a subset of patients? Yes, definitely yes, in a subset. If the child has lactose intolerance, that subset of patients with ASD having a lactose intolerance by having a gluten-free, casein-free diet might help. So definitely look into it more holistically than having basic ground rules and trying to apply. So it's like one size fits all never happens with autism spectrum disorder. Megavitamin diet, holding therapy, none of these have any evidence base at all. Last, moving on into my axis 5 or the psychosocial situation. This is very important. So, for instance, I manage my axis 1 very well. I give a developmental intervention. I give a speech and language intervention. I give some occupational therapy input, right? I prescribe medications for the self-injurious behavior. And then I give the child speech therapy as well. So OT, PT, physiotherapy, and your speech, everything is included. So your jigsaw puzzle has everything in it. But suppose your axis 5 is missing, then definitely there is going to be a lacunae. Why do I call it a lacunae? This is your psychosocial situation. So a child with neurodevelopmental disorders is like a very burdensome thing to any family, right? So unless and until you're able to hold hands with the family and explain to them why the child needs therapy, they're going to be lost to follow up at some stage. So the success of your therapy, the follow-up, the how regularly they're going to do what you say depends on what level of a rapport you have with your child and your patient and your parent. That is the most important thing. So the basic first few sessions, don't hesitate in spending it with the parent. Knowledge and attitude towards the parent. What do they feel about NDD? What do they feel about having a child with NDD? Take time to discuss this with the parent. What do they expect this child to gain? So most of the parents come and ask us, so at 3 years, no meaningful speech. At 4 years, will my child be able to go to normal school after this therapy? So try to be honest and tell them, yes, we do definitely sort of will see gains, but there is going to be some difference in deviation from the typically developing child. I think that needs to be addressed. They must be allowed to ventilate their distress and supported in the process. Definitely grief, addressing grief is very important. I'd be going into it a little later. Addressing the coping mechanisms of the family, having support systems is very essential. So psychoeducation, so that is very important in our center. We have regular parent therapy or parent classes where we sort of discuss on common things about autism, say behavior management, seizures in children, how do you manage self-injurious behavior, how do you do rewarding. So all these things are discussed with the parents, and parents have small group discussions. Then finally they come up with questions, and then they are sort of asked and the therapist tries to answer them as well. definitely individual support. Some parents who do have a diagnosable, say, depression or anxiety related to, or grief related to this, having a child with neurodevelopmental disorders, definitely, I think an independent referral to an adult psychiatrist is needed. So breaking the news, this can be a very big challenge. So I feel it must be done with a lot of sensitivity. Usually, as I said, even before you do an assessment for a child, there needs to be a pre-assessment, there needs to be a counseling. Once you finish the assessment, even telling the results, just don't throw numbers at a parent, right? It doesn't mean anything to them. So trying to explain about the diagnosis, about the prognosis, what do you expect to gain from the intervention needs to be done with very, very sensitively and taking the time to help the caregiver actually express their distress. I think that is very, very essential. Validating their emotions and allowing them to ventilate is going to see how well they're going to be compliant with your therapy and strategies advised by you. Definitely, parents do have grief, address the grief, they go through this denial. No, my child doesn't have autism. So I have seen this multiple parents coming and telling me, my child has ADHD with speech delay, right? I don't know where they get this combination from. The word ASD, unfortunately, carries a lot of stigma with it, right? So it is very difficult for a parent to accept and digest the fact that my child has ASD. So initially there is a lot of denial. That is the phase when they go for doctor shopping, one center to other center to the other, and then finally come to a tertiary care center. So address that denial, address that grief, address that anger. The next step is you're not giving my child the right diagnosis. Then they come down to saying, maybe doctor, if I give therapy, could it be because of lack of stimulation? I gave a lot of mobile phone when my child was 2 years. Maybe the stimulation lack and the use of mobile phone can present with this. Yes, it can present with that. So ask them to explain it and validate and talk to them about how can they make it better. And of course, finally accepting the diagnosis has to be there for them to get ongoing support for this child. So even if it is going to be a couple of sessions, it is time very well invested, and I think we need to do it. Addressing the guilt. This is another common emotion seen in parents because they feel that maybe I was upset, I had problems with my in-laws, I was not taking care of my child, I was working, I was not able to spend quality time with my child. Maybe all this has resulted in this presentation. So try to talk to the parent and address that guilt and allow them to ventilate as well. Coping strategies, give them time management, financial management. Having a child with neurodevelopmental disorders and having to get therapy definitely is going to be a very big financial burden for the family. So educate them about what are the resources. We have now multiple sort of insurance which can be sort of taken for these children, multiple governmental sort of laws where you can provide these children therapy in a setting. Multiple government centers do have early intervention centers. Try to give them that details and help them with how they can follow up for therapy in any of these centers, right? And coping, what is most important is each one of us have a very different way of coping, right? हम क्या करते हैं? कुछ लोग बहुत मन खराब लगता है तो बैठ के अलग से रोते हैं, कोई फ्रेंड्स के साथ जाके बोलते हैं, right? कोई भगवान को प्रार्थना करता है, right? Each one of us cope with that difficulty in very different ways, right? Some of us say it's all my karma, that's why I'm facing this, and move on and avoid it. That avoidant coping is not a very healthy way of coping. So as I said, teach them very healthy coping strategies. Try to link them with a support group so that they would be able to mutually support each other and progress in the treatment journey as well. So what is our CMC model? It is exactly what I had explained in my slides earlier. We have a multidisciplinary team input where we have clinical psychologists, occupational therapists, speech therapists, special educators, child psychiatrists. We have a member from the physical medicine and rehabilitation. We have pediatrics, developmental pediatrics, and pediatric neurology input. So we are able to, and of course, medical genetics as well. So we have a multidisciplinary team input sort of helping the child and the family. We have the maximum evidence-based management. As I had showed you, the psychoeducational profile device, which we used, is again evidence-based and research done at our center. We use the parent-mediated therapy. So here, parent is the co-therapist. So the therapist does not train the child. The therapist sits with the parent, helps the parent to identify what needs to be taught to the child, and empowers the parent. So this is what is the success of the treatment program here at CMC Vellore, I would say. The reason being, for example, if you're hungry, right, I might give you a meal. I might cook a dinner for you, say tomorrow's breakfast, but I'm not going to continue to do for you. I'm not going to be able to do it, nor are you going to be able to come back to me for that. But if I teach you the skill of cooking, then well, it's done. It's a job well done. So here, teaching a parent to manage a child with neurodevelopmental disorders, identify the area of needs. So this is the next goal I need to teach my child. Now my child has started, say, matching. Next is identification. Next is naming. I must move on. How I do this in steps. If you're able to teach this and empower the parent with that, that is the best job done for you. Then parental psychoeducation, as I said, is very important. It's a part of our CMC Vellore model, which is very integrated speech and OT sessions. We have both inpatient therapy and we have an effective home training program as well. Recently, we've included a 5-day brief intervention program, which we give for parents just as a quick snippet of what they would be able to get in the 3-month inpatient training program. And we found that very effective as well, because when we talk about differential reinforcement and how to give a reward, parents don't understand. But in the 5-day interventions, they sit down on the floor and dirty their hands, learn it from the therapist. So they're able to do it when they go back home. We found that very effective. And again, of course, regular follow-up, making and maintaining the surveillance and looking at how the trajectory of development is with the intervention is very essential. As I said, all this definitely happens only with empowering the family. Just like to conclude by saying early diagnosis and management is the need of the hour. Definitely a multi-axial diagnosis and monthly disciplinary team approach and evidence-based approach is going to be most effective. Assess your outcomes very objectively. Not to say that I feel the child is now better in language. I feel the child is better in socialization. No, do a pre and post intervention to show objective gains to a parent. That motivates them to work further for their child. Regular follow-up, and of course, advocacy for children with ASD. I think this is something every other person working with children need to take up the cause for. And definitely research. There are multiple research areas, but as you can see, most of them are Western literature. So we need to possibly have a lot of things from our centers as well to see that we have a very rich ASD data for the Indian children as well. So thank you so much for your patient listening. And I'm happy to take any questions. And these are my references, of course. There are quite a few references. I'm not sure if you'll be able to get them, but feel free to ask me any questions and I'm happy to take them.
Thank you. Thank you so much, ma'am. It was a very sincere and organized presentation. It will serve as a good reference for us in the future. So we are lucky all the nearly 275 people who have attended are very lucky to have undergone this seminar. Thank you so much, ma'am.
Thank you.
Over to chairpersons for their opening comments. Then we can take up the questions. Chairpersons, please.
Excellent presentation, ma'am. Very nice to hear and very beautifully describe the treatment part as well. And I think it gives a good learning to anybody how they can start off with autism and a very detailed thing about ABA and what exactly it does. Because many times, obviously, we hear these words, but what exactly is done, you've explained that very beautifully.
So thank you, Dr. Satya. It was excellent presentation, and I've learned so many things from this presentation, which will be useful not only for managing patients with ASD, I think for other disorders also, and the way you have reviewed the literature and linked it with clinical teaching. clinical work, clinical experience. I think there are a lot of MD students I can see in the audience, and they will all gain from this. And there are many questions which have been asked by you. Shall I proceed with the questions?
Yeah, sure, ma'am.
Dr. Gautam Saha is there, sir.
Okay.
Yes,
He will ask.
I know Dr. Satta from a long time, and
Good
she is
evening, sir.
really excellent. And I listened her presentation today from the very beginning, and I learned a lot again.
Thank you so much,
Dr.
sir.
Satta, and definitely thanks to Dr. Tufan Puti, Dr. Amrit, and Dr. Alim Bhai because of organizing such an excellent program as usual. Thank you.
Thank you so much, sir.
Thank you, sir. Yes, we can take the questions now.
So, so there is first question by Dr. Nasreen Bahar. Is it possible that a child has good communication skill and still can have autism?
So that's a nice question. As I said, usually we see social and communication deficits. So just expressive language alone would not sort of qualify for that. As I said, they can be high functioning autism spectrum disorder children who would have verbal language, who might be able to communicate even in sentences, but that restricted repertoire of interest, the rigidity, all that may be still present, but they might have a low average or average intelligence. Even sometimes you see even superior intelligence in children with autism. So therefore it might not be very pronounced, but definitely they can have ASD even though they have a good communication language skills as well. So they can communicate in sentences, but the prosody of language, for example, will be significantly affected, right? So that these are the subtle nuances where ASD, as I said, it's a very, very heterogeneous presentation, and across the spectrum, you see different levels of social and language impairment in these children.
Thank you.
Thank you so much.
Dr. Nidhil Amanullah, she asks, ma'am, any practical guide or books to be used as intervention, non-pharmacological?
There are.
That is a good question.
That's a very nice question. There are sort of few websites in which I can possibly share them. There are a few websites in which you can get some manualized, but most of these manualized, you have to basically use it in your population. For example, PEPAR has been validated in the Indian population by us. So there are a few such modules which have been validated by the Indian population as well, but some of them are not. Right? So module-based interventions, usually most of the centers do take up an eclectic approach. So they do take up some amount of OT, some speech therapy, and some sort of cognitive therapy and put together and then put it as an eclectic model. So each, as I said, depending on the place in which we work, if we work in a primary care center, even having, say, some OT and speech is very good. So if you're going to a tertiary care center with multiple other interventions, then possibly a module-based intervention may be more feasible. But then definitely, as I said, a lot more of validation of these manuals needs to be done in our Indian population.
Yeah, thank you. For example, the way you told that for CMC, what matters is I think you are empowering the parents. I think that is your USP.
Exactly.
That is your USP. So every center has its own USP.
Yes.
So before handing over to Dr. Manjri, my co-chairperson, I'll ask last question and then she can take other questions. Some kids socialize well, but are inconsistent in responding to name call alone when they are involved in playing. How to go about with this, ma'am? This was asked by Dr. Thivya RK.
So basically, what do you call that? It is preoccupation, right? These children might have a very good communication. For example, they might communicate in 3 or 4 word sentences, but that communication would be a need-based communication, right? I would be very busy playing with my toys. I would not make eye contact with you or listen to you. But the moment you say, Satya, I have an ice cream for you, immediately I drop the toy down and I look to you and I say, give me the ice cream. So you're wondering, what is this? This person has good sort of communication. She's communicating me, give me an ice cream. She has 4 word sentences. So is it autism at all? But being lost in my own sort of setup, being preoccupied, not being able to otherwise communicate. I have a need-based communication. That is also very typical of ASD, can be present. As I said, it is a very, very wide range, starting from being non-verbal to then having a few words, then having a need-based communication, then having a good communication itself, but the prosody of speech lacking. So across the spectrum, it can present with different levels of impairment and abilities. As I said in my first slide, that is why you call it as a spectrum disorder itself. So it can present with different shades. So it doesn't present as all black or white. It's all in shades of gray. Hope
Dr.
that answers
Manjari,
your
can
question.
take over from here. Dr.
Yes.
Rakesh Kumar Srivastava. Yeah.
Yeah, so somebody's asked, Dr. Rakesh has asked, what's the maximum amount of Risperidone in a 90 kg old child to control hyperactivity? The child is 17-year-old. And also, what is the percentage of associated mood disorders in autism?
Okay. So definitely adolescent with just, you have to see, of course, as I said, the cluster of symptoms. So if you're going to have only hyperactivity, rigidity, and repetitive restricted stereotype of interest, then an atypical antipsychotic is a good choice. But having said that, if it is a 19-year-old, if it is a 17-year-old who's 90 kgs, my choice of drug would not be risperidone at all. That is going to cause further weight gain. I would rather go in for aripiprazole. I would give it a time limited trial. I would tell the parent that I'm planning to give, say, about 5 to 7.5 milligrams of aripiprazole, and I'm going to start very low at 2.5. This is my target symptom. My target symptom is hyperactivity and aggression and repetitive behaviors. If we'll give it a 6 to 8 week trial, in case you see benefits, we would continue it. Otherwise, I think you need to taper it off as well. So definitely for a 90 kg child, my choice of medication would not be risperidone or olanzapine. It would be aripiprazole. If there are mood symptoms, yes, one-third, for 30 to 40% of children do have this very atypical presentations where they might be, it's whether it is an emotional dysregulation of an autism spectrum disordered child or whether it is an independent mood disorder is sometimes very difficult to tease out because you see multi layers of problems in these children. So this is a child with developmental delay. So one layer makes the psychopathology assessment a little more difficult. The second layer is on top an autism. On top of it, if you have a mood disorder, to delineate and describe that these are the symptoms specifically because of a mood becomes very, very difficult sometimes. But in case you see a typical pattern, so this child for 1 month, in 1 month, 5 days, the child is fine, no problems at all. The next 10 days, he's very restless, hyperactive, has sleep disturbance, would be very irritable. Then again, he calms down. And I see a very, very cyclical pattern to this. Maybe that pattern would suggest. So definitely in such complex cases, I would advise more of an inpatient sort of treatment for observing the children in different setups and then try on. Because unfortunately, we do start a medication without a clear target symptom. How long are you going to continue the medication? Right? That becomes the challenge in children with neurodevelopmental disorders. So it will be a polypharmacy. So that must not be done. Yes,
So,
sir.
ma'am, what would be the favorable medications in such a scenario?
So see, in case there is a mood disorder, as I said, if you have a clear typical pattern of a mood disorder, this up and down dysregulations clearly being there, whether it be a bipolar pattern qualifying for that, but you're not able to make a diagnosis, definitely aggression with a mood, a AED mood stabilizer would be good. Why am I saying AED mood stabilizer? Because again, children with neurodevelopmental disorders can have subtle EEG abnormalities. They might not have a clinical seizure, but they might have a EEG abnormality. So there is some subtle, so there is possibly a early onset, say, perinatal difficulty, antenatal problem, HIE sequelae, some EEG abnormality, mood dysregulation with ID, with sort of autism. Definitely here, one medication which is safer to continue, I would think, is a AED mood stabilizer, say like valproate or carbamazepine, would be a choice rather than giving an atypical antipsychotic high doses, then they gaining weight and then having all the others. So these children are very prone to side effects as well. So they can develop all the neurological side effects as well. They can develop the metabolic side effects as well. So be very careful before giving a long term of atypical antipsychotics. That would be my personal advice.
Do you have any difference in emotional dysregulation? Patients with emotional dysregulation?
Yes, sir. As I said, the clearly defining what is emotional dysregulation and a mood disorder might be a very, very difficult and challenging thing for most of us. So usually if you're able to observe the child over a period of time, you'd be able to make it. Because as they call it as the meltdowns in autism, in adolescence, the emotional dysregulation is very common. The only thing which might be able to sort of differentiate is you can ask them to maintain a sleep log. You can see whether there is a biological disturbance also, which is more commonly seen in a mood disorder rather than in an emotional dysregulation alone. And accordingly, you can tailor your medications.
Thank you, ma'am.
Thank you, sir.
Someone's asked current evidence of cannabidiol in behavioral problems in ASD.
Yeah. So I don't know who I know who's asked this question, but a very interesting question.
Yeah.
Yes, very interesting question. See, as far as our Indian literature goes, till today, we do not have any evidence base for use of cannabinoids in definitely treatment of behavioral disorders in children with autism. No.
How efficacious is the usage of L-carnosine in ASD?
Can I add something, madam?
Yes, yes,
For
sir. Please,
cannabinoids,
sir.
for cannabinoids,
Yes, sir. Please do.
there are indications in case of self-mutilatory behavior.
Yes.
In terms of hyperactivity and restlessness, there is psychomotor agitation. There are evidence. If you look at Western literature, we have
Yeah.
got some evidences.
Yeah, I
Indian
was
evidence
saying
is lacking, but
Indian population, we do not have a lot of studies. Western population, yes, especially
but
for the
we can try.
now. Yes, sir. A very, how should I say, well-informed trial. Again, what is your target symptom? How long would you give it? And you do not want these children to get into the other difficulties as well. So a very balanced and well-informed trial. Yes, definitely, yes.
Maybe self-mutilatory behavior that is very dangerous. We can try that. I think that's one indication we can.
But for self-mutilatory behavior, when you have naltrexone, which is an FDA-approved sort of medical treatment, that can be tried as well. Yes. Sorry, I missed the question, Dr. Manjari. Sorry.
Yeah, no problems.
Yep.
Dr. Vivek has asked how efficacious, and I think he means L-carnosine. What is the use of L-carnosine in both ASD and ADHD?
Yeah.
That's, I think a lot of people would have that question.
Yes. So L-carnosine, there is beginning to be some evidence in both the social and language areas of ASD. As I said, whether it is useful in only a subset of patients is something we'll have to know. Right? So that again, we need larger numbers to sort of say how much it is efficacious use in ASD. At the moment, yes, there are a lot of trials. There are a lot of positive evidence-based developing as well. But to use it as a regular treatment protocol to enter one of those treatment protocols, I think it's a long way to go.
Yeah, I think a couple of questions on the same thing. I think somebody has asked, and this is interesting, would like your take on this. A new drug introduced for autism, Altibrain, whether you have used it as well.
Sorry, I have not used it, so I can't vouch for it. I haven't. See, the difficulty is, as I said, there are a lot of these medications which are coming up as positive emerging therapies in ASD. Children are a very vulnerable population by themselves, and children with neurodevelopmental disorders with multiple comorbidity, unless and until there is a very strong evidence base, I think trying them just out of other data, I think I would be a little hesitant to do it at this stage.
Dose of naltrexone in managing.
There is a question on HBOT. Even I'm very curious to know. There is a question by Dr. Santosh. Ma'am, can you please enlighten us regarding HBOT use in ASD? I have seen a couple of kids with some improvement, especially in cognitive symptoms, echolalia, hyperactivity, after 50 sessions of HBOT.
I actually have not tried it personally myself. If the person has tried, please do try to say what are the areas in which you've seen. As I said, these are, so when as I put in that, how should I say, evidence-based medicine. So these medications are at case report levels. So there is a evidence base. So what is the bottom of the evidence base is few case reports. Then you have a case series. Then you have case control cohorts. Then you have RCTs. Then you have systematic reviews and meta-analysis. So unless and until there is a good evidence base with just few case reports using medications for these things, when they are much more sort of structured interventions for showing significant improvement in ASD symptoms, I don't think it is very clinically helpful for us to use it.
HBOT appears to be like a session.
Yes, ma'am. This exactly, it is again at a case report level, ma'am. It is not at it is, I don't know, I've not seen RCTs on this. Possibly if the person has seen, they can sort of unmute and say as well. There are only case reports on benefit of this. About 40 to 50 sessions is what they say before they see an improvement, and they see an improvement in cognitive skills. But as I said, definitely not more than a case report case series.
Dr. Manjri, you can continue.
Yeah, I think there are a lot more questions. Some interesting ones are how to differentiate obsessive behavior from repetitive self-injurious behavior.
Very nice question. So, coming back to our basics, if for it's for all the PGs, how do you define an obsession? A need to do something. So there it is ego dystonic, right? So if and this to clarify, believe me, trust me, is very difficult in a child with NDD. So theoretically, it's very easy to say this is how you differentiate an obsessive from a repetitive behavior. For instance, we have a child on the ward who repeatedly keeps talking about his difficulties, right? Wouldn't stop. So the pattern of presentation, right, is a repeated obsessive need to keep telling it, right? You can give a trial of an SSRI if there are other associated symptoms. But whether it is a repetitive behavior, usually most of the repetitive behaviors are in a motor realm. And OC is more of a OC also you can have, as I said, hand washing or other repetitive. But the OC in a ASD is more of that sticky, repeatedly talking about things. That is the obsession you may most commonly see. Whereas a repetitive behavior is more of a motor repetitive behavior. So these can be subtle clinical signs to differentiate. But having said that, to delineate the line and clearly say this is repetitive behavior, this is OCD, is very difficult.
Thank you, ma'am. Dr. Ravikant has asked on virtual autism. Your take on it? Children who had psychosocial deprivation and excess screen time.
Yes. So
Is
this
virtual autism unscientific technology, or is there any evidence supporting such a thing?
So yes, there has been now recently of multiple studies, especially after the COVID. So two reasons. One, these children did not have the normal social input as well. As I said, even the parent or the mother or the primary caregiver was mostly wearing masks, right? So they were not able to read the normal social cues, right? The emotional cues. So they did have a clear social deprivation. Of course, not to say about the social isolation, not to going having peer groups, not going elsewhere and exposure outside. Even in the home, the normal mother-infant interaction had a difficulty because of many such things being used even in a home setting. One. Two, virtual autism is about increased screen time. Yes, there is a lot of evidence about this coming about. Children with increased screen time during their early infancy. So about 1 to 2 years of age clearly had both a language delay and social deficits. So definitely we have to see that decreasing screen time is one of the first things you have to talk to a parent when you're seeing them the first time or second time itself, and even tell them about the concept of virtual autism if possible.
Role of stem cells in ASD. We have an IPS position statement also on it.
Sorry.
Role of stem cells,
Yes.
stem cell therapy in ASD. 2022 meta-analysis report from stem cell therapy significantly improves skill in patient with ASD. There was a report as per Dr. Ganesh.
Yes. As I said, again, I would go back to my Sackett diagram, would go back to say what is evidence-based. Definitely, stem cell is far from reaching anywhere as a common therapeutic intervention for autism at this state. I would stay on to that. Yes, there are reports coming now, but I think it's very, very far from prescribing as a normal therapeutic intervention. I know that it is sort of there, but not now as a therapeutic practice. I'm
Uh,
sure I'm sure Dr. Manjari can add or Dr. Amrit can add as well, because you have a lot of child psychiatrists here. So please do add in case there are differing opinions. I'm more than happy to listen.
So we do have a center here in Bombay, and we have a lot of kids and parents being brought on after having done multiple sessions of stem cell therapy. They spend lakhs of rupees, because I think each session is about 1.5, and they're told to do at least 5 or 6. And parents have come after therapy for that, because frankly, they haven't seen any change. I think it's just that parents are so vulnerable that they're looking for a miraculous change, and they're assured that this will, kind of bring, so that miracle word, or that this will bring cure, is what, unfortunately after that they've lost that precious time in therapy. And even in the center itself, they have to undergo therapy after stem cell. So I think if anything works, it's the therapy that is done post the stem cell in the center.
I think this is the common voice which has to be sort of said in a repetitive way again, or in an obsessive way, to all our parents. Because somehow, as Dr. Manjari very nicely put it, in this search for therapies, in the doctor shopping, the most important, the first 5 years of life is lost. And even after that, if there are gains, the gains are much, much slower than what you would expect in the first 5 years of life. So trying to impact on the parents at the first 5 years of life as the most crucial for the neurodevelopment to happen. And any stimulation at that time is absolutely essential. I think that is what we keep telling them again and again and again. Because yes, as very clearly Dr. Manjari had mentioned as well, I think it's the desperation of a parent. I wouldn't blame them. And if I feel I've tried this is not working, someone said, go here, I tried. So how many of us have heard this in our clinical practice? Don't worry if your child doesn't talk. 3 साल में कौन बोलता है? हम बोला है 5 साल में, हमारा नानी बोला है 6 साल में, कोई problem नहीं है. So that is what you get, right? So when parents get this input from 3 people, 4 people, 5 people in the family, as a mother, I am confused. I do sort of get deviated from my trajectory. So I think that is why I feel the emphasis must be on the primary care physicians and the pediatricians conveying this to their. So usually they don't directly come to a child psychiatrist, right? They do go to a pediatrician. So emphasizing that the initial first 5 years of life is so crucial, and that therefore the stimulation needs to be done. Then don't waste time. Intervention, intervention, intervention. Therapy, therapy, therapy. That is the first 3 lines of your management plan has to be mentioned to a parent. So all medications are adjunctive, I would say. So that needs to be very clearly told to a parent. Though it is a very difficult statement. If I say that there are not going to be any medications, it's very easy to say that sort of statement from a tertiary care center. People would anyway come back to us, right? But if I was a private practitioner, and हम बोलते हैं नहीं इसके लिए दवाई नहीं है, तो भाई आपके पास क्यों आना है? और कोई डॉक्टर है जो दवाई लिख के देता है, तो आपके पास क्यों आना है, right? So I understand as a parent where the desperation comes from, but as a fraternity of, say, child psychiatrists and pediatricians, we need to be advocacy. As I said, advocacy is the most important for these children, and we need to be doing it.
Ma'am, we'll try to cover.
एक मिनट अलीम, एक इंटरेस्टिंग क्वेश्चन है, मैं पूछ लेता हूँ, फिर तुम
जल्दी हाँ, speed up.
There is a question again on pharmacology, madam. Because I use these medications a lot. The rationality is sometimes irrational, but I've got good results. The combination of caffeine with melatonin, madam.
Sorry, melatonin with?
Caffeine.
Okay.
There's a combination that comes with the name of Attensure. I use it a lot because I treat it as a miracle. You know, kids who are not sleeping during the daytime, whatever sedatives you give, they're not coming down 4 o'clock, 5 o'clock. So I tried it out at 5 p.m. and 10 p.m. and got some very good results in unmanageable ASD patients. So have you ever used this, madam, combination, this caffeine with melatonin? This comes as a syrup.
I know that, sir, but we don't use a lot of combination medicine, sir. I would rather prefer for melatonin alone, and then if not helpful, would then escalate to the next step. I usually don't.
Yeah, this is the final point of escalation, madam. we
Yeah,
fail in
I
5
understand
syllabuses
that.
and then
I
we reach here.
understand that, but I think to sort of try it in a, as I said, the evidence-based, to try it in a tertiary care center, we must have a good level of evidence, which we do not at this stage for a
But
combination.
we might be part of the evidence, madam. If you don't try, how do we get the
Exactly.
evidence?
So we have to possibly start trying and prove and then create and then only practice it in our centers. So I think it is work in progress. Let me put it that way.
Ma'am, is incidence of ADHD and dyslexia in male and female children more or less the same with ASD?
Okay. So
ADHD and
ASD,
dyslexia in ASD.
okay,
Male versus
ASD itself has a male preponderance. We did speak about that. ASD with ADHD comorbid presentations are very common. ID with ASD, 1/3 of the children do have ID, right? So definitely that is going to have a male preponderance as well. But the ADHD symptom, the presentation can be different between the both genders. So male, the way the ASD hyperactivity presence can be very different from the impulsive blurting out of a female ASD. So the qualitative differences in the clinical presentation is what is going to be there.
Okay. Do you have any programs for preschool teachers?
We do sort of have a few training sessions for both pediatricians, sir, and for preschool teachers and for special educators. We'll definitely keep the team posted on any such upcoming programs as well.
Role of ECT, ma'am?
ECT, we have not tried anything. As I said, definitely not for ASD. If they're mentioning as any psychopathology with associated comorbid ASD, I think definitely not till now.
NRF2 inducer and regulator, redox and mitochondrial biology. I think active brain he's talking about. Amrit has
Yes.
posted.
As I said, all these, I put a series of a group of medications. None of these have a good evidence base, sir. Right? If you do an evidence-based search today about medications, the first line would come is all medications are only adjuncts used to treat specific symptomatology in ASD, and none of these are prescribed for ASD per se for improvement in social, cognition, communication skills. So that is the bottom line. There are multiple, I can see so many drugs being asked. So that is the bottom line, and that would be my answer as well.
A very practical question. Should ASD kids be sent to school with normal kids?
It is a very nice question. Depending on the level of intelligence of the child, sir, right? If it is a low average child, to encourage the social skills, I would say with a typically developing peer group, the child would benefit. But if this child has a significant delay as well with comorbid ASD, then definitely the child would be more aptly fitted for a special school rather than a typical school. So you need to see, as I said, it's very, very individually tailor-based. Therefore, it is hard to say one statement to cover most of these things.
Any
There
comments
is
on
a,
what
there is a one very interesting clinical question. How
Yes.
do you identify ASD in adults? Dr. Suresh has asked.
So
I
AD,
would be very interested in this
Yes, ma'am.
question
Yes, ma'am.
myself. Yeah.
So ADIR can be done to see autism diagnostic interview, so a schedule which you can see. As I said, now there's a lot of interest in two areas, adult ASD and adult ADHD.
Yes.
Still, it gets a lot gets missed. So I think definitely even in adult ASD, going back and getting the developmental history. I think going back to basics is the most important. Developmental history of speech or language delay, social delay, and then presenting with now might have a good language, as I said, with some rigidities in behavior alone and some very, very specified interests. You would have a high suspicion of ASD in these adults. Then you can possibly use one of these questionnaires to sort of validate a diagnosis.
Ma'am, won't those be mostly Aspergers who
Yes,
usually doesn't get
So as I
detected?
said, exactly. These are the high functioning ASD kids,
Yeah.
or what we used to earlier call them as Asperger's. Now we
And-
have it as an autism spectrum rather than having it as
Yeah.
specific
So, ma'am,
domain.
now because it is a spectrum now, ma'am, if you look at for everybody to understand, because people think autism means like schizophrenia, poor diagnosis, poor prognosis and everything. What is with the current in last 10 years, with research,
Ma'am,
with
any
the
comments on
advances?
modafinil?
Modafinil for in case the child has sort of inattention can be tried. But as I said, if you take the level 1, level 2, level 3 of evidence, it is your stimulants, then comes your atomoxetine and SNRI, then comes your clonidine, right? Very down the list. As I said, in children, again, it's not been approved as well. So I think before giving a trial, we have to look into the age of the child, the comorbid presentation of the child, the level of functioning, intellectual functioning of the child as well, and the comorbidity. If the child has a seizure, for example, most of these children, when you're dealing with a child with neurodevelopmental disorders, comorbidity is a rule. So as I said, that is why the multi-axial diagnosis is so important. So if I have a severe delay with some EEG abnormality, with an ASD, definitely medications needs to be used very judiciously. And I would be going with least number of medications. Polypharmacy is going to result in a lot of difficulties for these children. So definitely I would not advocate for that.
Thank you. Vishal, you were saying something, I think I cut you
Yeah,
off.
sorry. So I was asking, ma'am, just to for everybody to understand, because people think schizophrenia like autism, and very bad prognosis.
No.
So now with 10 years of, yeah,
As I said, it depends on the, as I said, you have some children who have, say, possibly low average intelligence with ASD traits. With early intervention, you see absolutely them moving very nicely and sort of getting into a regular stream school as well, right? So it depends on the level. So on the spectrum, the level of developmental delay, the level of severity of the ASD, plus or minus comorbid features. That is what is going to result in prognostication. That is why I said it's not like once I diagnose ASD, they're going to have a good prognosis, they're going to have a bad prognosis. Putting them into clear such pigeonholes will be very difficult. So even a borderline intelligence child with ASD, if there is intensive therapy given, might have a very good trajectory, right? But if there is going to be a say, borderline intelligence child with absolutely no therapeutic input at all, right? Then obviously the child is going to show a decline in the cognitive scores. The child is going to show a deterioration in the IQ as well. So then the child being having the same trajectory because the child had ASD with intelligence of borderline, it's not going to help. So it depends on how well, how intensive and how holistic the interventions are planned for most of these children, which is important.
and ma'am,
Ma'am, last question. Vishal, last question, very important. Regarding the lowest age when these medications can be prescribed, naltrexone, lowest age.
So usually, naltrexone specifically, yes. So usually, see, for even atypical antipsychotics, people do give it earlier, sir, but usually 3 plus is, I would not immediately initiate medications. Definitely not.
Clonidine?
Right? Clonidine, again, I do not initiate any medications less than 3 years. The reason is you must give the child a benefit of early intervention first.
Sure. We are doing that.
Only then, if not remitting, would I consider medications.
Melatonin?
And melatonin, yes, you can give it at 2.5, 3 as well if there is a sleep disturbance after having tried sleep hygiene. So bottom line, as I would say, because I don't want students to get a wrong impression for any of these medications, bottom line, intervention for autism therapy, which has been proved, having maximum evidence base, that is the first line. That is the second line. That is the third line. Only if that is not helping and there is a clear indication for pharmacological management would we have to go for that.
Thank you so much, ma'am. Before Amrit starts screaming, over to the chairpersons for the final remarks.
Sure. I'm sorry to have taken a longer session as well.
No, thank you
We are
so
delighted.
much. There
I
are
think there are
still
still a
many
lot of
questions.
questions.
There are
Yeah.
still many questions, but
We'll call madam again. Madam will come again.
Sure,
the way you have explained, one of the speakers.
Pharmacological evidence based तो कर सकते हैं. एक so then पूरा सब pharmacology का questions तो कर सकते हैं. No problem.
One
We'll
of
do it,
the
madam.
speakers has actually, has summed it very well. That person has said that, ma'am, the way you have explained every answer also tells us that how much experience you have in this. So that is one of the comments in the, and that sums up my summing up of your session also. It has been very, very I was very delighted I have learned a lot. It was very good session, very well deliberated and answered.
Thank you, ma'am.
Wonderful.
Manjari.
Thanks a lot.
Thank you, ma'am. Wonderful presentation, very elaborate, and I think a lot of questions are still unanswered. Still, I think a lot of PGs especially must be asking questions, but very elaborate and very detailed presentation.
Thank you so much.
Thank you, ma'am.
Thanks a lot for the
Tufan-
opportunity as well.
Tufan sir, over.
We have organization.
Thank you, Dr. Satya, for a nice presentation. It was really educative.
Thank you so
And
much.
I take a cue, which I strongly believe that every ASD case is individually unique. One cannot have a blanket mode of evaluation. And every patient should be detailedly evaluated. Because at time we miss many physical parts if we become fixed. And second, any psychotherapeutic or behavioral change or educative process with it. One has to be very clear with the parents how much time one needs. What happens, we have seen even when I was in mental health institute. They are not prepared to give that much of time. So what happens, this treatment is a failure. And we have to also take into consideration, I can tell with my 40 years of exposure to the mental ill, more than 40 years, the diagnosis changes. What was taught by my professor to be ASD, autism, not a spectrum disorder was not there, that concept was not there. That boy is still there in US, but that may won't confirm to the diagnosis of ASD now. So that also changes. One has to keep everything in mind. The parents have to have a great presence. For that, we have to be close to the parents. Otherwise, treatment breaks somewhere. Thank you very much. It was highly educating.
Thank you, sir.
Thank you, ma'am.
So on behalf
Thank
of the
you.
Indian Psychiatric Society, Odisha State Branch, it's a formal thank you I need to give. Satya madam was wonderful. What happens is when we have people from institutes, they generally speak on the what is given in books. They would speak on therapies and they have a little negative view towards medication. I think that was not there in madam's presentation. She was welcome, though she did not put it on the priority. She never made light of the pharmacological treatment because there are very few institutes, there are very few practicing psychiatrists who have a good clinical team in terms of psychology, in terms of everything. We don't have anybody. Now, then we need to take a call whether we can give some medication at the age of 1.5 years, 2 years. Teaching is something, practicing is something, practicing alone is something different. I think we need to be equipped enough to practice when we are alone. Because some of the cushions you get, we don't have, some of the cushions we have, you don't have. So somewhere, I think that it was a very good learning experience.
Very true.
And I think we had a gross overview of many of the things, but we would love to have you in 2 or 3 more sessions where we go into certain aspects of ASD, how to manage them, and that would be much more fruitful for us. I think the PGs have learned what they need to learn, but this whole sessions are also for practicing, psychiatrists.
Psychiatrists.
So
Yes.
we would psychiatrists, madam. We are in competition with the pediatricians nowadays when it comes to autism.
Sure.
And it's not a healthy competition. So we would, on behalf of the entire house, would request you to, once in a couple of months, we
I'll
will
have to
have
come
that
again.
covered. We need to cover autism is something which we lack.
Hi, Gautam, how are you?
And thank you, madam.
Thank
Mamta madam, she said.
Yeah, thank you.
One request.
Conducted. Manji, thank you.
Amrit bhai,
Bole,
One-
nice shirt.
one request. Madam Swata has presented. Yes, I think it will be really wise if we bring her again. And one topic is very important because you know that how to develop a autism clinic. Because many of us, I have one child psychiatric clinic separate, but many of us, we don't have. At least if we send to some other places, it might be very expensive or distances long. So it will be helpful if Madam guides us how to develop a autism clinic. Then many of us can make this and it will be really helpful to the patients.
Sure.
So thank you for your suggestion.
So much.
Our team of Vishal and Alim will work on it.
Sure.
So they're the main force nowadays. So So I would also like to thank Tufan sir for allowing us to do what we are doing. Torrent for helping us backstage. Vishal and Alim are the two most active people. So I would like to thank everybody. And we had a very good support base. You know, we had a peak of 275 today. And if you look
Yeah.
at the number of logins, it is more than 370. And that's not bad, madam. And we've
That
already
shows the
crossed
hunger.
more than 190 episodes. So
Yeah,
that's
that shows
in
the
spite
hunger
of
for learning.
in spite of
Yeah.
Alim and me being in the program, you know, that drives away 100 people out. So uske baad bhi itna na raha, that's good. So thank you again, everybody. We'll meet again. Good night.
Good
Have a
night.
lovely weekend.
Thank you, everyone. Thank you, everyone.
Thank you so much.
Good night.
Good night.
Bye.
Nice.
Bye-bye.
Take care.
Good night.
Good night.